We're expecting probably that people will be trickling in, but we're going to get started anyway. We have Allison Cutler here today. She has 38 years of healthcare experience, including 25 years in management and senior leadership levels in the fields of child, youth, and family health and public health. As Executive Director for the Population and Community Health Portfolio, Allison is responsible for Aboriginal health, rural health, and integrated primary and community care services. Allison has a Bachelor of Science in Nursing and a Master's of Science in Nursing Administration, and today she's going to be talking to us about developing an integrated care model in Oceanside, incorporating the learnings from the South Central Foundation. Please welcome Allison Cutler.
Thank you, Erin. Thanks, everybody, for coming, and I'm just really appreciative of the opportunity to talk with you today. Are you able to hear me okay? Oh, good. Okay, give me the thumbs, the signal if you can't hear me. Thanks. I don't have the biggest voice going on here. So I am very excited to be here today and to have an opportunity to talk with you, I hope, and share some of our experiences in island health and the learnings we've had. I think for me, as you heard in my intro there, I've been in this business a long time, and I have to tell you that right now, in the last year or so, I'm probably having more fun than I've ever had. We're on a wonderful journey with incredible partners, and I think, and my team, I think, will agree, that we think we're moving into a time of transformation rather than tweaking and reorganizing and just trying to make a bit more sense of the mess we sometimes find ourselves in. We're actually talking about transformation and doing things in a whole different way. I would really like to acknowledge that we are gathering on Coast Salish territory and thank the Coast Salish for welcoming us to their lands. I'd also like to introduce a couple of our team members that are here today, and partway through we're going to do a little bit of a buzz. Hopefully there'll be more people in the room, or it's going to be a very whispery buzz maybe, but I'll count on you to be excited. So with me today is Ian Knipe. Ian, if you could just, probably many of you know Ian. Ian is our Director for Aboriginal Health at Island Health, formerly known as Vancouver Island Health Authority. We decided to dump the authority part and speak more to what our vision would be. And also with me today is Phil Lawrence. Phil's our Director of Integrated Primary and Community Care, so a real force behind the strategy that we're going to be talking about today. We're going to have time in the morning to share your wisdom and to have hopefully some conversations and buzz, but please feel free to ask questions as you go. So what do I need to do to make this baby go? There we go. So what we're going to talk about today is why we're making these changes in island health, what did we learn from South Central, and how have we applied those learnings in Oceanside. So first off, I'd really like to know by a show of hands, who in the room feels they already know a lot about the South Central Foundation? Good, right answer. And a little? Okay, so that's good. I'll carry on as I'd planned to and kind of talk through what I learned. I wouldn't assume to be able to tell the story in the same way that the people from South Central can. And I know the First Nations Health Council, First Nations Health Authority have hosted trips and visits here. So I know some of you have had an opportunity to hear directly from them. And I would really encourage you, if you do get an opportunity, they have a conference every June, and they're very, very generous in sharing what they know. So for those of you in some of the other health authorities, you may want to take advantage of that. So why are we doing this? Why are we making these changes? It's a deceptively simple question, and the answer is incredibly complex, being that we're in this messy human world that we live in. Certainly, one of the reasons we're doing this is because we can't afford the healthcare system the way it's structured right now. You all have heard the stories, I'm sure, about healthcare costs escalating and the curve continuing, the gradient of the degree of spend as a proportion of the provincial budget getting steeper, and more of the provinces and federal government's dollars going to healthcare at the expense of other services and areas that are really important to influence the determinants of health. So healthcare services, best guess, 15 to 20% impact on actual health. So we do need, as a society, to think about what we value and where we make our expenditures. We also don't have the best outcomes. We, and those of you who work primarily with First Nations populations and in First Nations communities know that better than anyone about the disparities in health, and that despite our investments, we still have pretty staggering rates of complex chronic disease, mental illness, addictions, etc. So we're spending a lot of money. We're not getting to where we think we ought to with that degree of expenditure. Poor coordination of services, or maybe even very little no coordination of services some people would experience. So if any of you in the room have experienced a health challenge, a complex chronic illness, or help support a family member or friend through that, you know of which I speak, that you have to make that journey, often seemingly on your own, and you have to navigate between the different services. Often once you get into a service, it's fantastic, and you get what you need, but actually getting there is very difficult. Unless we get more patient-focused and actually even move beyond that and get more community health and population health-focused, we're going to continue to do the same thing. And you've all heard that adage from Einstein about the definition of insanity is continuing to do the same thing, expecting the same results. So is there a way out of this mess that we're in? Do we have an opportunity to actually create a system? I think, and many of my colleagues think, that the answer is yes. So at Island Health, we've recognized that there needs to be a better way, and certainly as has the First Nations Health Authority. We saw that yesterday in the celebration of cultures, and we heard that from the words that Joe Gallagher shared with the plenary yesterday afternoon. I think also the First Nations Health Authority vision of health through wellness is it just epitomizes that actually you're beginning to walk that walk now. So in Island Health, we committed as an organization to walk the talk of that there had to be a better way. And we saw that as one way to that path was to actually develop an integrated service model. And we started with integrated primary and community care, but we are now thinking that actually it's not just about primary and community care, it's actually about integrated care. So I'll use those words more today than just talking about integrated primary and community care. So we have restructured a little bit to give ourselves some space to actually focus on this work. We've created a team that Phil is leading to help form our strategy and to drive it forward. And we've developed some leadership tables where we are trying to engage the whole organization in this change, because it's not just a little team of integrated primary and community care. We need to impact the whole system to change the system. So our acute care partners, home and community care, mental health and substance use partners, they all need to be in this with us. And we have created tables where we can have those conversations, and we can talk about that a little bit more later. So we've created this new model for us, not new to society, and we base a lot of the principles of the model on what we learned from South Central Foundation and their NUKA model of health. We really find that we're building a bridge while we're standing on it, that we keep our learnings grow and change as we move forward, and we're trying to be nimble and adapt to that. The model that I'm going to describe, or the expression of the model at Oceanside Health Centre in Parksville, is we've only opened our final phase final phase for the big phase one on September 30th. So we're in very early days of understanding what these changes mean, and so no doubt in another year there'll be a little bit of a different story to tell. I really appreciated what Joe had to say yesterday around, he described that you all were in the First Nations Health Authority building a road, trying to figure out what kind of road, whether it was a bridge or what that bridge would look like. And also, you also had to you're building the vehicle on which to travel that road. So finding all the parts and fitting them together and deciding, is it a sports car or is it a four-wheel drive truck or the dreaded minivan that you all need to have. So I thought that, I really understand that feeling. We've been experiencing it in Island Health. The slide magically changed by itself, so I'll just leave it up there. So in 2011, a team of three of us from Island Health, Ian and I, and my executive medical director co-lead, Dr. Bob Burns, had an opportunity to visit South Central. We went on the trip organized by First Nations Health Council, and I can't say, I've said thank you many times, but I would repeat it here today because it was a game changer for all of us. And I hope you'll understand the enthusiasm that we left there with as I tell the story of what we learned and what we saw. So we learned about the organization, and it in and of itself is an amazing organization. And we also learned about their NUKA model of care, their primary care model. We wanted to know more, so we arranged follow-up phone calls, a follow-up video conference, and the team from the integrated primary care area of South Central was so generous with their time and sharing their floor plans, their job descriptions. And then the following summer, we sent another team, so 13 of us from Island Health went, a group of staff, physicians, representatives from divisions of family practice, went and had another opportunity to spread the learning that the three of us had, because I think some in the organization were getting a bit tired of hearing from Allison and Bob about we need to make some changes, and we have seen something amazing. So that turned out that Bob and I had got it right in terms of the impact, and the team of 13 that came away were as enthusiastic, and now we had a bigger core on which to start to spread the learnings. We were all just blown away with what they had accomplished, and over a period of time, so it wasn't a 2-week undertaking. At that time, their NUKA model of health had been in place for 13 years, and they shared with us they figured they're about halfway there. But they did challenge all the Health Authority and First Nations Health Council folks there to think about how we could spread further and faster and really build on the groundwork that they had created and some of the outcomes that they had experienced. So we went away and we wondered if we could do the same, if we could adopt some of the principles and the strategies within Island Health, being aware that we couldn't just plop a model from another organization in another community with different cultures, just import it as it is. But we thought there is so much strength in some of the underpinnings. We wanted to spread the learning about what they had accomplished and who they were, and also look at adapting it to fit our situation in Island Health and our diverse communities. You'll see on several of the slides, not this one, this is a photo that my colleague Bob took, but on many of the slides you'll see this South Central Foundation logo, and they've generously agreed for us to use some of the slides they used in their presentation. So this is their primary care center in Anchorage. And South Central Foundation is one of several healthcare foundations in Alaska. It's a Native Alaska organization, and they provide the healthcare for Native Alaskans in the Anchorage Bowl and down to the Aleutian Islands. So they have a full range of health care, and they also are the lead operator of the Alaska Native Medical Center, which is a hospital which is on the campus, and the earlier picture was of the campus. And the hospital is run in partnership with the other tribal organizations, And it was fascinating, I think, for the Health Council members in particular, to hear the story from the governors there about how they got there. So different views, different perspectives, feelings about Anchorage being the big guy on the team, and some of the smaller organizations feeling less power, under more control of the larger organization. But they got to a place where they're common in their goal, and they have their hard conversations in a room, and they walk out with one voice. So I think that was another good lesson for us. So the primary care model in Anchorage is referred to as NUKA, and it's a word that in the Alaska Native language means a strong structure and living things. It's a name that they've given to their whole health system. So the system is owned and operated by the customer owners. That's the people of Anchorage and the catchment area of the South Central Foundation. And the intent is to achieve physical, mental, emotional, spiritual health. It's a model that is so successful that it's won coveted international and national awards. The most recent really big award was the Baldrige Award for Quality in Healthcare last year. And they have outcomes that are they're an exemplar for the rest of us. So with their population, they have reduced their visits to emergency by 50%. They've reduced their hospitalizations by 60%. They've shortened length of stay. They have got much better markers on some of the indicators of chronic disease. So if you look at how stable people are with complex chronic disease, they are leaders in all of those markers. They also have significantly reduced their staff turnover. So that's a good marker of staff wellness. And when you walk in the doors of any of their buildings, so primarily we spent time in the primary care center, you can talk to anybody and they understand their business and how they contribute, and you just get a buzz that I haven't experienced in any organizations I've worked in. Just very beautiful buildings, and the beautiful Alaska Native artwork throughout all the buildings are just stellar. So it is a genuine system of care. It's delivered by customer owners. That's the term they use, which we found just to be pretty powerful. The CEO, Catherine Gottlieb, would say they're owners because they prepaid for it with their history. But certainly they are very intentional about those words and about how they implement their care. It's whole person focused, and it's built on a foundation of long-term relationships. The transfer of control to the customer owner, and integration of mind, body, and spirit, and a commitment to measurement and quality. And I'll give you some examples of that a little bit later, but I just described some of their outcomes, but it was just amazing what they're able to produce, and their intention around measuring and talking about quality and doing the PDSA cycles, the Plan, Do, Study, Act cycles. So if you just stop and think about those words for a few minutes that underpin their model. So system, customer owner, whole person focus. The foundation is a long-term relationship and commitment to measurement and quality. And I know for me and my colleagues, we couldn't say that we saw all of that in our own systems, and we hadn't experienced that. So it was just so powerful. So this is Catherine Gottlieb. In 1987, she was a young Alutiiq Filipino Alaska Native, and it was one of the cultural important things in Anchorage is that giving and telling of story. So every person that introduced themselves told their story, and it's a very blended culture because of the history of the world and how different cultures and moved in and out of Alaska. So she's very proud of her Alutiiq and Filipino heritage. So as a young woman, she joined the South Central Foundation as a secretary. And at that point, South Central in 1987 was a healthcare corporation before the transformation in their healthcare system there that provided limited dental and behavioral sciences to local Alaska Natives. Today, 28 years later, she's a grandmother, as well as the CEO of this large corporation, and which now provides broad healthcare services, so prevention through to acute tertiary palliative care, the whole system, to about 60,000 Alaska Natives living in the Anchorage Bowl. And the term Alaska Natives is the preferred term that the people of the Alaskan Natives like to be referred to, so that's why I'm using those words again intentionally. So her name is Catherine Gottlieb, and she really personifies South Central. She's an amazing person. And I think the story of how they started when the transformation occurred was that they listened. They stopped and they listened and they heard, and then they changed. So they were, one of the words that we really pulled away from their culture and their story of their organization is the word intention and being intentional. And we have found in our work that is so powerful. So very intentional listening over a period of months to what their constituents had to say before they moved and changed. And I think I heard Joe saying that yesterday too, around how important listening is. So they're very clear as an organization about what business they're in and what they want to achieve. And as I said earlier, you can walk into the you can speak to any staff member, just the person at the reception desk, a nurse somewhere in the Alaska Native Medical Center, and they can tell you very clearly and enthusiastically and articulately what their vision is, what their mission is, what their core concepts are, their operating principles, and how they contribute. So again, not an experience that I had, or Bob had, or Ian had in any of the organizations in which we had worked. And certainly I know in our health authority we use the Gallup poll to assess staff engagement, and boy, we've got a long way to go. Staff don't understand how they contribute, and they don't know the big picture in many, many situations. South Central Foundation is genius with acronyms. So these are their key points that, again, any staff member can tell you without pausing. Shared responsibility, commitment to quality, family wellness, SCF, South Central Foundation. Their operating principles. Again, you saw this yesterday with the evolution of the First Nations Health Authority, and you have adopted the concept of operating principles and chosen the word wellness as the acronym for you. I think a couple of the principles to highlight from South Central Foundation was that of relationship between the customer owner, the family, and the provider. So that's the core, is relationships and long-term relationship. Emphasis is on wellness and the whole person and their family and community. Intention, being intentional. Again, we heard that over and over again and saw that in their actions. Interests of the customer owner drive the system. This is sounding a little bit different than probably our lived experience in our some of our health systems here. And populations based, and services and programs built on the culture of the communities. This is the foundation, and this is something that we have adopted in Island Health. That primary health care is the cornerstone for families, for clients and their families over time, emphasis on the long-term relationship aimed at advancing the client's goals of health. So, primary care is a cornerstone, long-term relationship, include families as well as clients or the people we serve, and the focus is advancing the client's goals of health. So the reason that South Central got to thinking about why this was so important and how this could transform the system and create some different outcomes for their people was really getting clear on who is in control, who really makes the decisions. So if you have a motor vehicle accident, a car accident, you fall off your bike and you're badly injured and you're taken by ambulance to an emergency unit near you, you have very little control. You just need to trust that the people that are looking after you know what they need to do and know how to do it safely with a high quality. They're going to put those bones back together. They're going to stitch you up. They're going to do all the investigations that need to happen to make sure that they have patched the parts of your body, not your mind, spirit, and soul, but your body that are broken in that instance. But in day-to-day life, and when you have a chronic disease, mild, moderate, or complex, or you suffer from mental illness at whatever degree, or have an addictions issue, you're just living your life, actually the health system has very little control. And you may have experienced having a conversation with a healthcare provider, probably a physician, who gave you advice that went like, you should, I'm going to write you a prescription for, I need you to change this, and you walk out of the office and the provider has no control over whether you filled the prescription the way it was written at all. If you did, do you take it the way it was prescribed? Do you even understand the story you were told about how you should take it? Do you decide to share the prescription with a family member, or not even fill the prescription, but you think your neighbor had something like that, so you just borrow their leftover pills? So in reality, it's the family, it's your social network, it may be the media, it may be what you heard from Dr. Phil has way more importance than what your care provider told you. So the final decision that influences your outcomes is with the person in the NUKA model, the customer owner. The influences are family, friends, and coworkers, religion, values, much more than the system. This gives us some real opportunities to influence behavior, because it's the behavior of the person on their journey to health that makes the difference. How you decide, and we heard again yesterday, the challenges of the beefy chiefs, and again, individuals within the communities making choices about their own behaviors that would impact their health. And our current model is really one of tests, diagnoses, treatments without attending to the whole person and what it takes to actually make the changes. Again, I just love this slide from South Central, which again they've so graciously shared. So it's about when you want to hit a target, when you want to reach a goal, get to an outcome, can you use a rock or is it really a bird? And in an industrial mechanistics endeavor, like medicine can be, you can, if you practice hard enough, you can throw the rock and hit the target. If you practice, you're going to get it right. But in a complex, messy human system, you're actually just throwing the bird. So it's not about hitting a target, it's what are the attractors? How can we make it so irresistible for the individual to get to where we think we want to go? So what is it going to take? What are all those influences that need to happen? And it really is thinking about our healthcare system as a service industry, not an industrial industry. And we sure don't in our current model. We leave it to the service recipient to find their way, and we talk about our own piece of it, and we give advice often, and I'm generalizing, but overall, the takeaway from most people's experience with the healthcare system is not one where they feel in control and can influence, but that they are recipients of a service that they may have a little bit of say in, but at the end of the day, they actually control their behaviors. So this is a summary of the NUKA system. It's about relationship, it's customer driven, they They pride themselves on same-day access. So in their primary care center, if you call before 3 o'clock and be there by the time they close, they'll see you. None of this 3-week wait. They use a technique called max packing, and that is that they do everything that they can do for you in that day. So there is no sign that says only one problem today, please, or make 2 appointments if you have 2 problems that you might have seen in your own primary care physician's office. Staff work at the top of their license. They have service agreements with other parts of the system, which is brilliant. So they have service agreements between primary care and some of the specialty surgical services, that the primary care team will work up the patient to a certain degree so that they would never refer someone who had abdominal pain not yet diagnosed. Because sometimes that turns out to be constipation, and that's not a good use of the surgeon's time. So they have these commitments back and forth about the level of assessment that the primary care team will do, and then the specialty service, so example of a surgeon, has made a commitment about how fast they'll see the person, and if they do need a surgical intervention, how fast that will happen. So it's not that more passive, I'm going to make a referral, wait to hear from the surgeon, then they'll see you, then you go on another wait list. They have totally changed their approach in that. Really big on job progression, career ladders, mentoring. So the story of Catherine Gottlieb, who's now CEO, coming in the door as a secretary, currently the CEO, has been supported in her career laddering and her education. She's very highly educated. They don't hire based on, I've got a vacancy, I need to find someone. As people walk through the door, if they see that they fit with their organization, they just bring them on. And it's about fit, and actually, do you really want to live in Alaska? Have you been here in the winter? I know it's pretty when you came on your cruise, but, and then they fit them into the roles that they have available. A lot about giving and receiving story. They're very accountable. And they put services into their culture rather than culture into their services. Subtle change of words, very important. Asset-based, and they really focus on their operational principles. So that's the story of South Central and what we learned. And again, I don't want to presume to be able to tell the story of South Central the way that they could. But I've shared with you my learnings, and what we'd like to do now, and you might want to join up some tables because we've got some pretty sparse seating here, is just have a little buzz, and let's take 5-10 minutes, we'll see where the conversation goes, and talk about how you see that we could apply these learnings within the communities that you're working in BC. Sound okay? You want to move a little bit? Our team's going to wander around a bit and gather some of the conversations. Then we'll just have a quick feedback. I'm not asking you to write it down and do flip charts. Let's just have a bit of a conversation. Yeah, go give and tell story, and I'm going to come off the podium. All right, it'd be great if you moved up a little bit, and we'll get going and just hear a little bit from you about what the ahas were at your tables. I'll just give you a sec to get settled. Okay, you have a hall pass. Okay, so any ahas people want to share? Or things that had great meaning? Yes.
Oh my God, do we need a mic? Well, at our table we had a privilege to hear about sort of a development that is happening actually in my area in Fraser Health. And so I was very pleased to hear that there is really the opportunity to build or integrate services into the culture that is already a long-standing culture, and that's for me is the aha, to really bring the services into the culture and not the other way around.
Mm-hmm. Yeah, the back table had a lot of conversation about that as well. Other folks want to share anything?
I nominated myself the scribe, so do I need to use that mic?
Yeah, yes, you do.
Okay.
Because they're podcasting this.
I was with Petra on the table at the front, and some themes that came up, I think, were around an amazing leader in South Central and the power of that. Also, examples of the importance of partnership, and I really appreciated the advice that you were giving around that. Also, co-location came up, the importance of where you're locating services in the example. And I'm not sure who said this, but wouldn't it be nice to see greater consistency in our efforts across the province? Because a lot of us are doing somewhat similar work.
Great, and someone already touched on embedding culture and services and vice versa, and the importance of that. A couple of other points that we talked about at our table was just the incredible opportunities with the rise of the First Nations Health Authority and Health Canada stepping back, that there's going to be more flexibility in terms of how we approach services and the ability to be innovative. And of course, it wouldn't be a discussion if we didn't talk about non-insured health benefits. Lots of challenges there, but again, the potential to be innovative as we work with the First Nations Health Authority and the regional health authorities.
Great, thanks. So I'll just try to tell you a little bit of the story of the Oceanside Health Centre and the work we're doing in Island Health, and then leave some more time at the end for questions and more discussion. It was great to hear the conversations that you had. So this is a front door shot of our new Oceanside Health Centre that opened on June 24th. This is a pre-opening shot. I can still see the sawhorse. Clearly not as beautiful and culturally appropriate building as the primary care centre in Anchorage, but nevertheless, we're really pleased to have this resource in the community and within the health authority. So Oceanside is kind of the local coin name for the area of Parksville-Qualicum on Vancouver Island on the east coast. It also includes some more rural communities, Arrington Coombs, where the goats are on the roof, and Hilliers, a more of a farming community. Has a population of about 49,000, but 500,000 visitors a year. The beaches in Parksville and Qualicum are very well known. Sandcastle competitions, internationally known, etc. It doesn't have a hospital. There are 3 hospitals within 30 to 45 minutes away, one in Comox, St. Joe's, West Coast General in Port Alberni, and Nanaimo Regional in Nanaimo, which is the biggest of the 3. It's a community that's wanted a hospital forever. So lots and lots of conversations about why don't we have a hospital, look at this community, look at that community, and you know the patchwork of acute care services over the province, history, tradition, etc. Today, if we're doing a planning exercise, it would look very different, but it's incredibly difficult to close a hospital in a community. So the population of Oceanside is older, and the older population is growing significantly. It's a real retirement community. The population tends to be healthier, although above average amounts of moderate chronic disease. There is certainly pockets of vulnerable populations. They tend to get missed in the population because the bulk of the population is older and well-educated, quite wealthy, and very organized. So we had an opportunity. So when we looked at what the gaps were in terms of some of the services, there really was a gap on the primary care side. There's a lot of people who are residents who do not have family doctors, or they've kept their family physician in Richmond or in Calgary or wherever because they knew they dare not give that up before they found one. And there was a real need for urgent care. So a lot of travel on the highway to Nanaimo, Comox, West Coast for mild, moderate, and of course appropriately severe levels of emergent care. So the world evolved as it does, and there was an opportunity within the Health Authority to create a health center. And we thought, we don't just want to build an urgent care center, we want a more comprehensive building. And this is it's starting about 5 years ago, some of this conversation. So the decision was, let's co-locate our community services in this building. And let's see if we can bring in the diagnostics, the lab, and imaging that were already in the community with private providers, and create a primary care center, have our own staff. We were thinking that we would actually have a private builder build it and run it. It turned out that it's VHA built and owned, which is great because as our care model changed, it's so much easier to have the health authority in the driver's seat. So we opened our first services on June 24th of this year. So that was bringing in all our community services, most of our community services. We brought in home and community care, mental health and substance use, seniors mental health or the seniors outreach team, our integrated health network staff, our diabetes education staff. Our child, youth, family, public health staff did not move in because they'd had an opportunity that happened faster to have a new build with the school district and with Ministry for Children and Family Development. So they're co-located in a building called Family Place. So eventually we'll morph the reporting relationship of those staff into our geographic structure, but right now it's separate. We have a lab. It's a private lab, Life Labs. So they're they do blood draws and EKGs and things like that. And we bought the local radiology clinic. So we have a VHA-run medical imaging department. We have an urgent care, a medical daycare, and primary care. So the urgent care opened on September 16th with some of the medical daycare services. We're just ramping that up. And our primary care clinic with its first panel opened September 30th. So very little experience on that one yet. We wanted Oceanside, so as we went through our process of thinking about what integration might look like, we decided we had a great opportunity with co-locating all that staff to have Oceanside be our first demonstration of our integrated care model. And as we moved along, we've gone quite big and bold with our e-health strategy in Island Health, and we have an alliance agreement with Cerner, and we're actually creating electronic health records. So Oceanside is the demonstration of that movement to one record, one person, one record, one plan of health, which is our strategy. So we've been building the bridge as we walked on it, as the world changed around us and we saw there were opportunities, and we didn't have a model. Normally when you build a building, you have the functional plan, you know what the service is going to look like, and you design a building around that. We had a building that was being built, and with a particular design, we were able to influence the primary care area, and we borrowed shamelessly from South Central and have the same kind of model with a collaborative center in the middle and then the rooms down either side, and we have a combination of exam rooms and talking rooms. In primary care, often you go to see your physician, lots of times you don't have to take your clothes off to get dealt with what you need to be dealt with, so that we have talking rooms, not just trying to make it more comfortable and more client focused. So we really wanted to accomplish all those things that South Central had done. Think about more long-term relationships, not episodic care. More client-driven, not provider-driven. Team-based, not single professional-based. Trying to deal with the whole person, not just one problem at a time. So this is what we had, and this slide's old. You can see it's November 17th, and because it's a picture, we couldn't change the text, but our current realities, we had all these services, our home care, mental health, diabetes education center, the acute care hospitals around, seniors health, integrated health networks, all in separate space around the building, all with separate intake processes and separate records. And the poor person seeking service trying to navigate that. And what we wanted was that model where there's one door, it's always the right door, and that the client is engaged and they're in the center with their family and informal supports, and the service is wrapped around and coordinated for that person. So we had two parallel processes going on. We had our regional work, which was trying to help us go from an emerging vision that we had when we came back from South Central to actually what a model would look like. So this is our, we've gone through several iterations of this and needed to respond to input from many of the partners and stakeholders we had. On your tables there was copies, and we have lots of extras, so Ian can pop those around. The full model. This is just the center. So you see we have the client or patient. We have a lot of debate what we can call the person. I think we should have the person, but the person, the family, informal supports in the center. The physician and team and the primary care provider could include a nurse practitioner is the next ring. The public health services, so those health protection, prevention, promotion services are the next ring, and the community infrastructure. So that's where we get at the context of the community, the culture, and the services of other services available, and really where we can influence determinants of health. So those three rings are wrapped around the person and their family at all times. And then the circles depict those episodic services. So when you have a need for a hospital service, it's episodic and you're in and out, but you're always grounded to your primary care team. So that longitudinal relationship over time. The same with other community health services or social services. Expanded primary care services, so there's a core team around everybody, but then you may need other parts, home care or social service, mental health services. Housing and residential, another support that isn't for most people isn't over their lifetime, it's a period of time. And then specialty services or specialist services. So part of our journey with our community staff was really to have some conversations, and boy, some of them were really hard, about what is a comprehensive basket of primary care services. What of our community-based services really are primary care, and what are specialty? And let me tell you, the conversation about what's specialty and what isn't was hard, because everybody thought they were special. So we wanted, as we designed our model, and we'll come back to how we got to how we divided up those teams a little bit later. So of course, the client experience is paramount, so we started thinking about what do we want this to look like and feel like and be experienced like by the people we serve. And we had done the things that many of you have done, I'm sure. We'd done patient journey mapping and engaged patients and clients in that, and the stories and the circuitous routes you had to go to get somewhere, and how you had to, because we are siloed. That's a reality, that the conversation about your diabetes was different than the conversation about dementia, was different than the conversation about depression and anxiety. It was different than the conversation about the caregiver's anxiety. And we created what we called our wall of shame. The multiple referral forms that we had were all different, not just areas of not just home care, but within home care, there's a multitude of referral forms. So we looked at that, and the people we serve also told us really clearly that they only wanted to tell their story once. They wanted us to be good stewards of their information and make it easy for them to move through without having to start all over every time. So we pulled away from all our engagement that we wanted a single entry point for all services. Same-day service would be ideal. We wanted a blend of scheduled and unscheduled appointments. Warm handovers, so changing our language. So we don't internally in Oceanside, we don't refer to each other. So a home care nurse will not refer to the diabetes education clinician or to mental health. They huddle as a team and they do what we call warm handovers. We would refer out. So if a resident of Oceanside who was getting service from us at the center needed to have some specialty service in Victoria, that would be a referral. But within the center, we do warm handovers and we attempt to do full service at every appointment. So we took from learnings from South Central, and we've introduced 2 new roles. A clinical coordinator, and this is in primary care first, and we're emulating that in our community team, but we haven't got that all sorted out yet. So the clinical coordinator who manages that panel of patients or a group. So with the primary care team, they have a number of people that receive their family physician primary care services from them. We've got that clinical coordinator. We're just intrigued by South Central's role of behavioral health. I believe they called it clinician. We've changed it to consultant. So this is a master's prepared clinical counselor, addictions management specialties or training, who works with people around their behavior change. So again, getting at that, who's in control, and to make a difference in your health, you have to change a behavior. And it needs to be centered in what's important to you, so your goal of health, and why you would want to make a change. So the behavioral health consultant would work with people who wouldn't be eligible for our normal mental health and regular normal mental health and substance use services. They wouldn't have a diagnostic category that would make them eligible. So the behavioral health consultant looks at short-term interventions, mild, moderate anxiety, behavior change to support chronic disease management. The focus has shifted from programs and services to meeting the clients' and their families' health needs. So we would have, in our previous iteration, the box that had all the different programs on the top, it would be, I'm a home care nurse and this is a service I can provide. I need to refer you to X. Or you'll have to find it, or worse, I'm a home care nurse and this is a service I provide, full stop. And the client and their family carry on. Services performed by integrated interdisciplinary teams, and so we had to go on a journey to figure out what those teams would look like, and that we knew we wanted some quick response to be able to support the needs of the clients, the people we served in urgent care and primary care. So to get to that max packing, you might come in with one thing. It's clear there's other things going on. How can we get you those supports at that visit, not I'm going to refer you to. It's all about attachment to primary care because, of course, the principle is long-term relationship with a primary care provider is the core foundation, and everything drives from and back to primary care. So we're always looking to make sure that people are hooked up with a primary care provider, either in our center, now that we have some capacity, or within the community, because there is a little bit of capacity out there. The client's electronic health record is a source of truth, and we talk about a health plan and health goals. We're not fully there yet. We're just starting on that journey. We have technology to enable us. We have a geographic focus, so we're actually structured in a reporting relationship. So everybody's peeled away from their old programs, and now they're part of a structure of Oceanside Health Services. And we have standardized processes and tools to improve consistency. So that is actually another lesson from South Central. What they said, they embrace variability if it adds value, but they found a lot of that actually having those standardized processes and tools that made it easy for people to follow the care path and to do the performance monitoring and the quality work was very helpful. So this may be familiar to many of you, the Kaiser complexity of need triangle, also used by Ministry of Health in their care management strategy. So we did, as we were thinking about our teams, we were thinking about how complex are the care needs, and we need to pay attention to all those levels. So the broadest level, level 1, is around a healthy population, and moving through to the pointy end is the most complex of the people we serve. And of course there's gradation, and people move up and down. So thankfully you're not in the, most people do not, we would hope they would not stay in that complex care area, but they do need special services when they have those needs, and then they would be supported to get back to primary care. We also thought about how do, what really is an integrated care process, because we want one way in. There's one door. It's very easy to find, and however you get there, it will be the right door. We have one referral form now, not 47. So we did a lot of work with our team around getting comfortable with what an integrated care process would look like. And this is consistent throughout the building with small variations. So this is the primary care model, steps. And throughout, what the staff now understand is what they need to do at each step and who can do it. And that was a bit of a revelation, because most of our staff can do most parts. Again, that conversation about who's special. And what do they need to know to do that? So from just checking in that greeting, reception function, through gathering the appropriate data, doing the assessments, supporting, creating the first care plan, supporting self-management for those in primary care, optimizing the care plan, so that's really where you're focusing on the goals, and then transitioning the client out. So there's this same kind of care path exists in urgent care and medical daycare, and with the community team upstairs. So our teams in primary care, this is actually mostly a new team. We have a physician, and the first physician in was one from the community, and that had always been our intent. And she has a small group of patients relative to most family practice, so she had about 600 patients. And so they've come over, most of them, a couple haven't, but they were consented and moved over with her to the Oceanside Health Centre. We have a nurse practitioner as part of the team, the clinical coordinator role I talked about earlier, medical office assistant. It's actually a clinical office assistant is how we ended up framing it, because it's trying to get away from medical, and a scheduler, and then with access to the role of the behavioral consultant. So there'll be the warm handoff between the clinical coordinator, the family physician, the nurse practitioner, to the behavioral health consultant. And based on the NUKA model, one behavioral health consultant for 2 panels. So we only have the 1 panel now, and we're in the process of recruiting another physician, but meanwhile we're intaking our new patients, starting giving priority to people who live in the Oceanside area who don't have a family physician at all. So as they're coming in, they're agreeing to be cared for by a team and to work with us in this new way. I should say also that the behavioral health consultant role was one of our former mental health staff role, and we actually looked at the staff, what the staff were doing and who they were serving. With our mental health and substance use staff, we identified that out of 17 FTEs, 3 actually were doing primary care work. Unfortunately, not all of them were qualified to fit the behavioral health consultant role, so we're working through that process, but that's where the folks came from. And the scheduler was one of our previous admin support staff. So when we moved from 5 buildings to 1, we had some efficiencies in terms of reception and intake. So integrated community care team, this is one of the biggest changes. So this is all our community staff that I described. Now one large team. We've divided them geographically just for efficiency, north and south. They're working in a whole different way through that integrated care process. We have created a role called an integrated service coordinator. So the referral that comes in is viewed by the service coordinator and assigned geographically to the appropriate team. The team huddles a couple of times a day and decides who the most appropriate clinician ought to be. So a referral doesn't come in and say, I need diabetes education. It describes the concerns the client has, and then the team determines the most appropriate way for them to be cared for. And they have access to specialty services who sit right there with them. It's actually an open area, broken up with modular furniture, and as in most open area concepts, folks are in the building, have an assigned workspace, others are floating. Lots of huddle space, collaboration space, phone booths for confidential calls, that kind of thing. So this was the hard conversation I referred to earlier. What's primary care, what's specialty? And we got to that actually. There are 3 key functions for our specialty services: knowledge transfer to primary care and the integrated community teams, consultation with primary care, and direct care for the most serious, complex, and unstable clients. So those at the pointy end of the complexity of need triangle. And again, moving, because everything flows from and drives back to primary care. That connection is never lost with primary care. And this is another way of describing it, as we looked at when we might actually have our clients provided their care by a member of that specialty team, in this case, the mental health team, and how, as you move up, it's consultation and education, but the client themselves is staying linked to primary care, and that link never breaks. Again, very different from now. Primary care physicians would say, I send a referral to mental health at Island Health, and I never hear back. I don't know whether my patient was seen or not seen, but we're being very deliberative and intentional about always linking with the primary care physician. So we've got some key enablers, data, and again, we're not there yet. I live for the day that we have the data wall that South Central Foundation has, where they understand how well their teams are performing and what outcomes they're getting. We will be closer to be able to get there when we have one system, not a multitude of systems, as we go with our new electronic health record. Technology to support, so of course telehealth, we're telehealth enabled, and linked, our urgent care is linked to the Nanaimo emergency department, so they can in real time do consultations and look at the medical imaging stuff. Was a public health nurse, so I don't have much of my clinical lingo left. And those standardized processes, which is one example, was that integrated care process and all the work in behind that. This is a big change management endeavor, and it's a struggle for some folks. So we do have very deliberate, again, in change management strategies through all of next year, and we have a real focus on evaluation. So we have engaged an external evaluator, a team from Dalhousie and UVic, and they're doing a very comprehensive evaluation. They're just finishing up the current state. They've done random mail-out surveys to the community members, and we've got incredible. 2 weeks ago, I had heard we were at 37% response rate, which is incredible. Maybe everyone wants to tell us we really should have a hospital, but I hope not. Also with physicians and staff in the community, kind of and clients that we serve. And then the evaluation will be over 2 years with a number of questions based on the triple aims. So have we been able to improve population health? What's the client and the staff experience? And what about cost? Did we really need a building to do this or not? We've got some really incredible work that will happen. Of course, patient stories. So just a couple to share. So, and this is Meredith Saxon. Of course, I have her permission to tell her story and show her picture. So she was our first patient to arrive by ambulance to urgent care. She has a complex chronic disease and very frequent visits to Nanaimo Regional Hospital. So we were able to meet her care needs that day and get her ready to go, hooked, hand off back to our primary care physician. Some of the community team was able to make a follow-up plan with her, and she returned home with her husband and her in their vehicle that he had followed the ambulance. They were both thrilled. He was ecstatic and said, "This is so great. Now I'll be able to drive my daughter to work." So it's that whole family, client, and what has meaning to people. Another incredible thing that happened, and we were just actually quite kind of like hair on the back of your neck. So it was the Thursday before the August long weekend, and a gentleman walked into the clinic to the mental health drop-in. He had been living in a tent for over 10 years between Parksville and Qualicum in a wooded area. He had some mental health and substance use issues, but he'd also recently had a harsh diagnosis of pancreatic cancer. And he was in trouble. He was in pain, and he was lost. So in our normals, flashback, a home care nurse wouldn't visit a tent to do an assessment. There was lots of reasons, if we looked at our old model, that we would have had a very hard time putting together a service plan. The mental health clinician saw him in the walk-in clinic. He did have a family doctor. A contact was made. The fellow was welcoming some service. He knew he was in trouble and he was in a lot of pain. So the team huddled, and at first there was a little bit of, "Oh, we don't normally do this." No, client in the center, it's up to us to wrap around the services. So they made a plan. And even at 6 o'clock on the Friday night before a long weekend, in the summer, they're putting the plan together. By Saturday morning, he was in some housing that we knew about through our mental health program. We had the orders from the oncologist, so he could have his pain medication begun in pain management. And he was just ecstatic and relieved. And we just felt so proud of the team that they actually got their head around, we do things differently now. The other one that I'll talk about is max packing. So again, a client into urgent care. He came in with a medical concern, but it was clear on triage that he had mental health concerns. So again, we have a walk-in clinic mental health clinician available during office hours. So that person was just brought right into urgent care after the medical needs were stabilized, and they began to manage the concerns of the day and a connection, a hard wired connection with the family physician. This is just our self-check-in, because we're the first in our health authority to just swipe your care card and you're checked in and it tells you where you go. Jimmy Pattison Center in Surrey has it, but it took a while to get to the island. And those are our fantastic volunteers. So what's the opportunity? Well, we think it's huge based on the learnings from South Central. We don't have any of our own health outcome data yet, but we're starting to hear some client satisfaction data, and also some staff. Some staff are still struggling. They miss the old way. And so what we're thinking about now is how we can spread that within the health authority. We have some great work going on in some other communities with partners, with divisions of family practice. So we're actually having a health authority conversation with our senior leaders on Friday about what's our spread capacity and how fast can we move forward. So I can't do UDA. If Bob was here, he'd be doing this slide, but he's not here. So my summary is it's do or do not. There's no try. And we have an urgent need to transform our system. And there's some models and some learnings that we can take and move forward. So that's our intention within Island Health, and look forward to questions and more conversation. And we have about 7 more minutes. Yeah, there's 2 relatively small First Nations, Qualicum and, help me in with the correct, well, Nanoose, but correct, the correct. Yeah. So they're relatively small. The Nanoose First Nation has a beautiful new health center. So we're having conversations right now about how one of our nurse practitioners can serve the communities, and also, of course, our community staff will we outreaching, they're not just delivering service in the community. So we've had some conversations, and that needs to continue.
I know that we're getting a nurse practitioner now, and one of the I'm loud enough without a mic. Oh. Anyway, well, I have a loud enough voice. I come from a clan that has women that can talk very loud. I lost my train of thought.
Nurse practitioner you're talking about.
Yeah, we're getting our nurse practitioner, but our physicians actually come to the health center every so often as well to work within the health center itself.
Mm-hmm.
We're getting, there was a difficulty with the location on the new hospital on Haida Gwaii, but it's located in Queen Charlotte City, which is about 6 miles to 7 miles. I'm still on the miles, by the way. Don't understand the flex. So it's kind of cool. I like the whole idea. One of the things that you said is you lost your clinical lingo. I wanted to mention that when it's client-centered or individual-centered or patient-centered, whatever you want to, the human being-centered is one of the things I like. Is that clinical language doesn't cut it anyway.
Right. Very true.
What I'm finding with clinical language or any kind of language in the field, it's called a separating language. Nobody talks to one another because they don't understand what each other's saying. I was curious about the role of the behavioral change health consultant. At first, I could feel my knickers getting in a knot because most often it's us that has to change their behavior and not the individual that's sitting in the room with us. Behavior in the sense that we might be judging them.
Right. So the role would be to work with the client, the person that we're providing service to, around what their health goals are. So,
I
yeah.
I'm just trying to make a point. I guess I'm
You're
trying
very
to make
right.
a point with some of the language, although we use English and it's supposed to be this really great language to communicate with, everybody interprets it differently. So I was having a hard time quickly trying to wrap my head around that. I like that idea, by the way.
Great.
I'm not saying it's bad. Other than that, I'm just grateful that there's humanness coming back into, a couple hundred years ago. My grandmother was a nurse. I mean, you talk about bridge. I know that I'm a bridge, and it's not exactly a fun place to be. My grandmother arrived in Skidegate in 1927, married a non-human being. She's Scottish, and I ain't about to part with that clan system either, right? So, but it was just like, and having to work within the community herself, it's just, and going back, because she always went to the home.
Mm-hmm.
She always went and worked with the family. She was there during the big TB epidemic, losing whole families, fighting with the government for medication. So she actually used traditional medicine because it was available. I mean, she used the knowledge. It's just interesting, And so when I think about the time, what the whole profession, the helping profession was to start with, we seem to be stepping backward back into that place again, where it's all about the individual. What we have a way that in our language, and I lost it. I got little pieces, but we have a way. We call it holding the individual up. That's supporting,
Mm-hmm.
right? So I'm just excited. I'm blown away. And I think, and I'm sitting here thinking, I have Fraser Health here, I have Vancouver Island Health here, and I'm wondering, where is Northern Health?
At another session, I'm thinking.
Where is Northern Health Authority?
I was going to say, one of the things that I really appreciated about South Central is the focus on service and patient-centered. And I think that that's a message that we can carry forward and never forget about, because again, just learning about what the aspirations of the person is and how we can support them to meet their aspirations, I think is really critical.
All right. Well, thank you so much. Sorry, Brennan, did you? Oh, sure, go for it. I didn't count long enough.
Thank you for your presentation. That's loud. I always appreciate hearing about experiences of people who've been and visited the South Central Foundation, and to know that Island Health is going down the path to implement some change that's reflective of our community's needs. And I'm really excited to hear about the electronic health record that you're using at the clinic or the health center. And I'm just wondering if there's been any discussion or thought about how the one record system might integrate or collaborate with the Aboriginal community electronic health records that are used on the island.
And I think, Brennan, there's been some high-level conversation and acknowledgement that there would be a value in that. Perhaps it's a conversation that needs to continue. So, and we're quite far from the electronic health record. That's probably a 3-year time frame, but at least we've made that commitment. So we're starting with pieces of it, with an ambulatory record in primary care that we can use across our system. So we need to keep talking about that. And we need to figure out how to get rid of all the old legacy systems too, right? Yes.
It's probably a very long conversation, but the big piece I got from the South Central experience is that they integrated services into culture, not the other way around, which often is token anyway. So can you speak a bit about that, please?
Well, I probably couldn't do it justice, but we definitely saw that, and it was one of those. One of their operating principles, as you saw on that list, was how important that was, and they are so intentional about checking themselves on on what decisions and how they make them. So, and the conversation we had at our back table at the little buzz there was that had a lot of meaning for people, and we really struggle with that in our current reality. We kind of tack on, and we talk about cultural safety. Well, that's so far from where South Central is. So I think within First Nations Health Authority, there's an incredible opportunity to take that and go.
What initiative is Oceanside doing to move down that road?
We have not done a lot of work in that area. We have, but we do have our First Nations 2 communities engaged, and we're starting with what would it look like for. We have a resource, a nurse practitioner. So we're starting the conversation about, so what does that look like? As opposed to VHA saying, we have a nurse practitioner, would you like us to visit the health center Monday and Wednesday every second week? It's let's sit down and talk about what the needs are and how we could augment the gaps in service that you have in your community. So we're baby steps in this area, but we acknowledge that it's work we need to do.
Thank you. I just have one other quick question. Just looking at this Oceanside model and also hearing about projects that are happening in Fraser, where First Nations are partnering with their health authority, I'm just wondering if there's opportunities that you see on Vancouver Island for similar primary care centers to be established in partnership with communities.
Most definitely there are, and we have we're having different conversations about health centers and also integrated services, because you don't need a building to deliver integrated care. It really helps when services are co-located, because those conversations, those huddles can happen in the moment in the day. So we have some focused work going on in Cowichan and in Mount Waddington, and beginning in Tofino, and in Cowichan and in Mount Waddington, the First Nations communities are engaged. So again, we're trying to go down the path together. So, and there's huge opportunities, as you know, based on our communities on the island. So it's lunchtime. I'm the one holding you back from lunch. So I just wanted to say very much thank you. I'm on the screen now, so thank you. My email was up there, but you'll get the presentation, so you'll be able to see that. We're happy to tell our story and have more conversations, look for opportunities to partner, and we are open for tours some days and not others, but we're happy to show off the center and show in real time the work that we're doing there. Thanks for your interest and for your time. Thank you very much. Hi, Nucca.